Ehi ragazzi,
Amori,
Ragazzi,
come state?
bene, bene.
Allo,
Hello.
allo. Allo. You know that.
So,
Sebinio
Ciao
is here,
Sebigno.
Sebinio.
Ciao
Sebigno.
Sebigno. You know that this
Hello.
weekend we had an incredible, amazing concert in Rimini for the National Dermatology Conference in Rimini.
Really?
Wow, it
wow.
was a
We
big success.
know because we found one of the band, or one of the participants of the band, Eduardo. Eduardo.
Eduardo,
Yes, yeah.
he went also to the Ado?
Yes.
Ah, hai capito. Sì, sì, Eduardo was playing guitar with us.
And how did it go? You were in a good shape?
Ah, it went very well. Very well. Can I show you something?
Yeah, of course.
Yeah, sure.
First
Can
of
I
all,
show you something?
please do, but we lost our tradition. Cheers, guys.
Cheers, guys, of course, of course. Allora, just a moment. Let me see if I can. Can you see it?
Yes.
Wow.
Ah,
Amazing.
Ah,
mamma mia,
how
everybody
how many
jumping, everybody
how many
jumping.
participants?
Well,
I-
at the party, there were something like 900 people.
Wow.
Wow, it's amazing.
Wow.
So average
It's a party of dermatologists.
mean age 25.
Uh, As you can imagine, me and Emilio just came back from Prague, and Eado did not have the same vibes.
No, not the same
People
vibes,
were
correct?
the average age was not 25, and
Yeah.
people were not dancing that way.
No.
We wish we were there in Rimini.
Sebinho. I just saw the shirt of Sebinho. What a nice
Yeah.
shirt is this? Yeah.
Wow,
He came
wow,
from
wow.
Hawaii. He
Oh
came from
my
Hawaii.
God.
He's in a summer mood already. You're ready
Yeah.
for the summer.
Sevigno is becoming more and more handsome. Mamma mia.
By the way, today, so I left Prague today with 9 degrees Celsius, and I landed in Athens at 29. So I was wearing a coat and a jumper, and when I just landed, I want to take everything out.
Everything out. Yeah, I can imagine.
So we will be there in 2 weeks.
Looking forward to that.
Sì. Allora, Emilio, I suppose that you have to greet all our friends.
My problem is that I just entered in the Zoom meeting last moment, so probably I missed many.
Ah, so
But
I
I
can
can
tell
read. No, no,
you.
no. I can read. Canada. For me, the first is Canada.
No, I have Berlin,
Okay,
Netherlands,
go.
Uzbekistan, Sweden, Poland, Beirut. Hello, guys. Parma, UK, Yoshkar Ola, Brescia, Hungary, France, Russia, Chicago, Libya, Canada, Costiera Amalfitana. Wow, this is beautiful. And UK again, Turkey, Romania, Byblos, UK again. I don't see
Where,
Canada,
where's
Sweden,
Biblos?
Ukraine. I don't know. Madrid, Argentina, Russia again, South Africa, and then Macedonia, Roga, or Riga, maybe. Canada, yes, Emilio, continue.
Costiera Amalfitana. UK, Turkey, Romania, Byblos. Where is Byblos?
I
Biblos, I
have no
don't
idea.
know.
Lebanon, 25 kilometers north to Beirut, as
Ah,
you just
Ah,
said.
beautiful.
Ukraine, Spain, Argentina. I don't know why always when I read Argentina, I shout and yeah, probably because of the last World Congress, I guess.
Because of
Because of
Maradona,
Gabriel.
Because of Maradona, yeah, also could be.
Because of Maradona.
Yeah. Russia, South Africa. Yeah, the rest I think you did. The rest I think you did. Slovakia, Brazil, Greece, Portugal, Serbia, everywhere.
Fantastico, fantastico.
At the last episode, we should do the map again.
The map again. Yeah, okay, sure, of course.
Fantastico.
Okay, let's go.
Allora, vai. Are you ever surprised by biopsy results, This is the topic for today, Amazing results. Sometimes we know what we are going to excise, but from time to time we get surprising results. Okay. You know what? I prepared different topics based on you, based on what you are going to cover.
Really? So you have now 2 or 3 presentations ready?
I have two, 3 options. Yeah.
Okay, nice.
Yeah. Yes, sometimes, sometimes. Yeah. Okay.
So
what is the difference, Sebi, between yes, sometimes, and
and
sometimes?
sometimes.
Yes, sometimes is only yes. Sometimes is sometimes.
Okay. Va bene, va bene. Allora, who's going to start? Our
Nisa, as
Nisa.
always.
Our Nisa,
Okay.
as always.
Thank you so much.
Mm.
Yes.
Mm.
Let's start with this one.
Mm-hmm.
23-year-old male with a lesion on the medial aspect of his left foot. History more than 10 years. Was bleeding easily after trauma.
Mm.
Okay, this is the macro image. And this
Okay.
is the dermoscopy. There's a scale.
Okay, let's do so. What did you expect from the histology?
Actually, I was expecting about Poroma, maybe,
Poroma.
because the patient has a young age, maybe Kaposi sarcoma,
Okay.
because it's on the foot, just like that. And here's the dermatoscopy. There's a scale and some bloods. And I try to remove the scale, and this is the underlying features. As you can see, there's a rainbow pattern, and on the North Pole, there are some branched vessels. Scale, and what's your diagnosis here? What do you expect?
So, so it's not a Poroma because you said, did you expect? Well,
and this is the dermatoscopy.
Very hard to say. Pyogenic
What do you expect
granuloma?
with this one?
Something vascular, I would say. Yeah.
Kaposi.
Pyogenic granuloma. Kaposi, I mean, is a young guy, but pyogenic granuloma, why not?
Yeah.
And history is more than 10 years. Long-standing lesion.
Okay.
We don't believe the history.
We don't trust.
And the only diagnosis I didn't consider here was basal cell carcinoma or trichoblastoma, because it was located on the foot and it's not an hair-bearing site. And histopathology was here, trichoblastoma, which was very surprising to me. Don't you think so, guys?
Yes.
Extremely.
Definitely.
Yeah.
Definitely.
Yeah, it was a great surprise
is,
to me.
just to mention, trichoblastoma is the benign counterpart of BCC.
Yeah,
so,
actually histopathology was almost similar with basal cell carcinoma. It was very hard for pathologists to differentiate these two entities because of the uncommon localization of the lesion. And my pathologist needs some immunohistochemistry, and after all those stainings, and she decided that this is a trichoblastoma.
Okay.
So it was an unexpected diagnosis, and the
Let's
lesion is located on the
Nisa, let's call it, in order to be all happy, we can call it aneurysmatic trichoblastoma, and then we're gonna, then we're gonna be happy.
Yeah, great, Emilios. And here, this is the back of an elderly male, and the lesion is here. What do you think it is? What's your diagnosis? Melanoma?
Melanoma in situ, yes.
One
And
option.
maybe melanoma with some regressive features, right?
Yeah. Yeah.
Yeah, I was expecting a melanoma in situ here with partial regression, maybe more than. But histopathology is this. We have basal cell carcinoma here, and we have also a dysplastic nevus, a collision of dysplastic nevus and the basal cell carcinoma. Let's go back to the lesion. And I think it doesn't really look like a basal cell carcinoma. So the diagnosis was a surprise to me because I didn't consider here basal cell carcinoma in my differentials.
No, not at all.
Yeah. And here, there's one more interesting lesion. This is a scalp of, I think the patient was around around his 30s, and it was on the scalp, a pigmented lesion. And as you can see, there's an alopecia.
Well, yeah, probably this is a nevus sebaceous.
Nevus sebaceous, yeah.
Yeah.
I was also thinking about nevus sebaceous. Yeah.
Yeah. So it means that this could be one of the three. This very
Syringocystadenoma papilliferum.
Exactly.
Yeah.
This is one, or
Exactly.
trichoblastoma again.
Trichoblastoma
again.
Or BCC.
Exactly.
Or BCC.
Yeah, or BCC. I was thinking the same with you, my dear friends. Even though the flat part didn't look like nevus sebaceous, those were my differentials. But histopathology was very interesting because it was a porocarcinoma.
Oh, wow.
And without underlying nevus sebaceous. So
by the way,
it was a surprise to me.
Yeah, definitely. But dermoscopy is somehow, I mean, the vessels we see dermatoscopically are clearly coiled.
Yeah.
Coiled, exactly.
Which should reduce the probability of BCC or trichoblastoma. That's the only thing we can say.
Very good. Very good.
Very interesting lesion, yeah. And one more case. What's your preferential diagnosis here with the macro images? The patient is a 25-year-old male.
Nevus with trauma.
Anterior shin, duration for a long time, and the middle part has turned white in the last 1 year.
Yeah, nevus or a SEPK.
This is dermatoscopy.
Clonal SEPK.
Clonal SEPK. Do you think that does it fit with clonal seborrheic keratosis?
Clonal seborrheic keratosis is very peculiar. So
very peculiar.
I will go for that.
The patient is a young male. So do we expect to see a clonal seborrheic keratosis on the leg, on the shin of a young male?
No.
No.
No. So actually, I didn't consider here clonal seborrheic keratosis with this dermatoscopy. I thought that this could be a dermatofibroma, melanoma, because of the white structureless center, and there are some white lines and some radial lines at the periphery. So maybe melanoma is arising on a congenital nevus or something like that. And here are my differential diagnosis. Also Spitz nevus. Histopathology was Konstantinos, you got it. This was a clonal seborrheic keratosis.
Wow.
Beautiful.
Yeah.
Clonal SEPKs are so peculiar.
Yeah.
I think we should do an episode only on clonal SEPKs.
Yeah. And you can see the fibrosis here, which corresponds to central white structureless part, and immunohistochemistry.
Yes, beautiful,
was negative. Yeah.
Wonderful.
So, this is the last case. I think this is a bit challenging again. This is the soul of a 65-year-old male. history 1 month, and the patient has a heart transplantation, and he is under intensive immunosuppression because heart transplantation was 2 months earlier, and the patient has a 1 month history.
Okay.
So this is a dermatoscopy.
Poroma.
Poroma, yeah. And this is the pigmented part.
Poroma.
You can say
Poroma.
poroma because we have some poroma-like vessels. But since the patient is immunosuppressed, so also Kaposi sarcoma is possible, right? Because there's an history of heart transplantation and he is under immunosuppression. So here my differentials are poroma, Kaposi sarcoma, maybe atypical pyogenic granuloma because of the very acute onset, and also melanoma because of these polymorphic vessels. But histopathology, we published this case. Histopathology was something different. This was a deep fungal infection.
Wow.
And what's the reason? Trichophyton rubrum, which is exceptional because we know that with Trichophyton rubrum, we have superficial dermatophyte infections. And this was a deep fungal infection. And you can see we also in the cultures, and this is the histopathologic features. And we published this case. I think it's very interesting because the lesions in under immunosuppressions can be really very challenging.
Wow, beautiful.
Yeah,
this
it
is really impressive. Really impressive.
Yeah, I have a lot of interesting cases, but I'm stopping here.
Okay.
Do another one. Do just one more.
Jump one more?
Yes.
Okay, one more. Maybe ear lesion. This is also interesting. A pigmented flat lesion on the ear, and here's dermatoscopy. A chaotic lesion, as you can see. I think lesions located on the ear sometimes can be very challenging because of the architecture, anatomy of this area. And here, a very chaotic lesion with numerous brown clots, eccentric structureless areas, some vessels, dotted vessels, white structureless backgrounds. So what's your diagnosis here?
Thinking, I mean, that we speak about crazy diagnosis, I would say seb-care.
Seborrheic keratosis, What else?
Well, if it's not a melanoma,
if it's not a melanoma,
if it's not a melanoma, is seb-care or
or another
or crazy pigmented Bowen or something like that.
Exactly. Histopathology was here. Pigmented Bowen's disease, I think, which is very interesting because there were no scale here, just brown structureless, eccentric brown structureless areas and some brown clots. Maybe, we have here some coiled vessels. I think it's very interesting. I have also the histopathology slides, and this case was discussed in Harold's session on Tuesdays. And he also confirmed that this is a typical Bowen's disease, which mimics a melanoma.
Wonderful, wonderful case.
Amazing.
Thank you.
Pigmented Bowen's disease, by the way, is so difficult to diagnose. It's impressive. Sometimes it's almost impossible.
Of course, I have to admit that in a case like this, located on the face, on the ear, I cannot understand the meaning of pigmented Bowen's as compared to pigmented actinic keratosis. I mean, I don't understand.
We are speaking about very just subtle. It's just one disease.
Well, the difference is that pigmented actinic keratosis can progress to SCC. Pigmented Bowen's most likely not.
It's viral, but if this is the case, then this should be pigmented actinic keratosis because it's unexposed. It's a classic unexposed site.
Bene.
Wonderful.
Who's going next?
Thank you.
Whoever.
Okay, I go. No, Constantinos.
You go, Emilio. Go.
Great. Since Nisa stopped with finished with a case on the face, I start with a case on the face.
Eh,
Yeah, that's the clinical.
Yes.
Clinically, what it looks like more.
Seborrheic
LM,
keratosis.
seborrheic keratosis, yeah.
lentigo maligna to me.
Okay, we have a total disagreement.
Okay.
Yeah. Okay, good.
Lentigo maligna.
Yeah,
Still.
more on the side of
Lentigo
melanoma.
maligna.
Okay.
Melanoma.
So what do you do in terms of management?
Punch biopsy or shape biopsy?
Yeah, but look at the lesion also.
But
Size and shape and where
very easy to excise. A
very
small
easy to
lifting.
excise.
Okay. Okay.
I do excision.
It's
Yeah.
also the direction of the lesion is
Yeah, yeah, yeah.
It's perfect.
so
It's perfect.
convenient, so
I
convenient
agree.
to excise.
Yeah, and
I
also
agree.
has the wrinkle there. You'll do the lifting. He will be very happy.
Correct. So same as you, I thought that clinically more on the side of sep care, but with dermoscopy, no. I mean, no. So we excised it, and it was a solar lendigo.
Okay.
Ah, come on.
Yes.
Like,
And now retroscopy. This
Sharp demarcation, sharp demarcated borders. Yeah.
yeah, and at least in my keynote presentation, there is visible network, but I don't know in the Zoom how visible it is.
No, we don't see it.
Yeah. But not evident,
Yeah.
not predominant.
No.
so it's
No.
one of the 14% of cases where the inverse approach falls out of place.
Yeah.
Yeah,
Yeah.
yeah. But yeah, a shame. I mean, because it's not a small one. It's a lesion that you expect that you will be able to diagnose. Yeah. And then
Yes.
you apply the dermoscope and you say, okay, oh, well, we have to excise it, but don't worry, it's gonna be a very, very thin melanoma. Don't worry. Solar lendigo.
By
Of
the
course,
way,
good for the patient, definitely.
good for the patient. But let me just highlight here that this is the added value of confocal microscopy.
Yeah,
So
exactly.
if you saw that patient not in your private practice and you saw it in the hospital and you sent him directly to confocal right next to it, and they did a confocal, like this is the case. I
Yeah,
think these are the cases where confocal has the highest value of all.
Yeah. But we didn't. In this case, we didn't.
Yeah.
Yeah, because I mean, yeah, we thought it's an easy case. I mean, this has
Yeah.
to be excised. I mean, this has to be excised. I mean, don't. Okay, next one. On the scalp, unfortunately, I do not have, although I know, don't shout at me. I don't have dermoscopy of this. However, I decided to show it because, okay, even without dermoscopy, what do you think it could be?
Squamous cell.
Squamous cell.
Erosive
Erosive
pustular.
Yeah, of course, if it's not a squamous cell, by the way. So, I mean,
This one. Do you think it could be erosive pustular?
Yes.
It's
Yeah.
too much. It's
I've seen worse.
yeah. Okay, so although I consider myself very good nowadays at diagnosing erosive pustular dermatosis, here we biopsied.
Yes.
Here we biopsied, yeah, and the result of the biopsy was nothing at all, yeah. Nothing
therefore, erosive.
Lymphocytic infiltration
Therefore,
or something.
steroids, and it's gone.
Yeah.
I've seen many, but this was one of the most impressive ones.
Yes, it is. It is very impressive.
I did not expect it at all. But I thought that it's gonna be squamous cell carcinoma for sure. Okay, good. But then, of course, the question was resolved after what happened with steroids. Yeah, obviously.
Yeah.
So it was confirmed. Similar scenario: scalp, bald man with erosive lesions. Among them, there is the upper one, which has also a little bit of pus, so pretty much in line with erosive pustular dermatosis. But the one on the front looks like this.
SCC.
Yeah.
Yeah. So would you biopsy this one at least?
Yes.
Or go first with steroid on everybody,
Yeah.
and then see
on,
what.
on everybody that you see with a lesion on the scalp, go with
No,
steroids.
don't laugh. We do it often. I mean, when you can be reasonably sure that the patient will come back after 1 week or two,
Yes.
then we do it. We do it.
Yeah.
Okay, in this case, we took a small punch of both. Yeah, and the result was nothing. I mean, a specific inflammation. Okay, but it was not a huge surprise because we could think about it as an alternative. The point is that the patient comes back, everything goes rather good on the left side of the scalp where the previous problem was, but now we see this on the right side of the scalp.
Yeah.
Come on.
Yes. You biopsy here.
Yeah.
Yeah,
That should be a BCC, no?
Yes.
Come on, look at
BCC.
the pigmented area. The pigment.
Yeah.
It should be a BC.
It should be BCC.
It should be, but it could be anything, but it should be a BCC.
Yeah. Okay. Perfect.
And biopsy result, nothing.
BCC.
Okay.
All good. If this was not a BCC, that would be a problem. I mean, because to my eyes, the pigmented area is a clear-cut BCC. It's not
BCC.
It's not the ulceration. It's the pigmented area. I mean, this cannot correspond to. Okay, good. But the patient comes back, of course, after a while.
Yeah.
And in the left part again, we have these superficial erosion. This is the place that had been biopsied before, and the result was nothing, unspecific inflammation. Yeah. Then we excise the BCC on the other side, and then on the left side again we have this erosion, and again we don't have a dermatoscopic photo because we simply considered it's fully in line with a recurrence of the erosive pustular dermatosis. And I would say that now it looks even more like an erosive pustular dermatosis than before. Before it was a little bit tricky. And we biopsy again this part because it was not responding to the steroids. And the diagnosis was BCC.
Don't say desmoplastic melanoma.
BCC. But can you imagine that we biopsied the first time? It was nothing. We have this recurrence on the same side that looks more like a erosive dermatosis now, and it's a BCC.
Yeah. These scalps are incredible.
These scalps are incredible. One more scalp. Clinical dermoscopy. You biopsy or steroids?
I do cryo, to be honest. It looks like actinic.
More on the side of squamous, yeah.
Squamous. Okay. So you biopsy.
Yeah.
Okay. By the way, at the same time, there is also in the front of the scalp, a few centimeters away, there is also this area that I don't know if you agree that looks quite a lot like erosive pustular.
Yeah.
Yes.
Yeah.
Okay. This looks like an erosive pustular, but the other one not so much.
No.
Okay. Good. So again, we punch both of them erosive pustular. Erosive pustular, to explain to the people correctly, you never get an histopathologic report saying erosive pustular dermatosis.
You get inflammation, inflammatory cells, inflammatory infiltrate, and so on.
Exactly. Okay. So inflammatory was the result in both. Okay. And then the patient comes back, steroids, then everything was fine. And then the patient comes back after a couple of weeks or maybe 1 month with a new lesion, which is this, and that's dermoscopy. So you have the previous history of erosive pustular dermatosis. You see this. What do you think it is?
Yeah, EPD.
Erosive pustular dermatosis.
Yeah, there's pus as well.
Again?
There's pus as well. Yeah. And that's a squamous cell carcinoma.
There are a lot of vessels.
Yeah.
I mean, crazy. This one was not, and this one was a squamous cell carcinoma.
So we may conclude that this erosive pustular dermatosis is a paraneoplastic sign.
That's really, I find it really fascinating in terms of, I mean, I want to understand more about this entity, so strange. So I would like to learn more. Let's conclude that, okay, now that we are good at recognizing, perfect, all these tricks that we do are fine, but just pay attention. I mean, don't underestimate it. Don't
Yes.
underestimate it, because especially when it develops on some damaged scalps, which usually it does, then it often coexists with cancer, with
Okay.
squamous cell carcinomas.
And
And
if I can summarize, Emilios, exactly what you said, you give steroids for 2 weeks. Bring the patient back in 2 weeks. If you have no response, biopsy.
Yeah.
Yeah, of course. But then the point is that in the long term, because usually these patients you're gonna follow long term for several reasons, not because they have erosive pustular, but because they have their sun damage and so on and so on. In the course of the long term monitoring, it's quite likely that at some times you're gonna find inflammatory lesions, and some other times you're gonna find cancerous lesions. So these things go somehow together.
Yes.
In the course. Okay, we changed completely. That's the clinical. I have to tell you that this is a person with albinism. Okay, that's the close up, and that is what you see dermatoscopically. The lesion is located on the back,
Bubbles.
on the lower back. Yeah, and it looks like Bowen's or not.
Yeah.
Well, but it could be easily
A
melanoma as well.
melanotic melanoma.
Melanoma.
Okay.
Melanoma as well.
Which
Good.
is very rare in
Perfect.
albinism.
Perfect. Okay. So that's why I showed the case, because of course our first impression was Bowen. I think that for anybody the first impression was Bowen, but here there is an important risk, because if you think Bowen's, that means that you might cry.
Yeah.
Yeah.
And unfortunately, this was a melanoma, and not a very thin one. It was 1.4, so it was a very good. Thank God that we thought about it and we biopsied. Of course, we did just a punch at the beginning, just a punch to confirm that it's Bowen.
Desmoplastic.
Yeah. But it was it was a melanoma, and as also you said, a reason why we didn't think about melanoma much was that in albino patients it's extremely rare. Why non-melanoma skin cancer is not rare? So
they are common.
Common sense
Exactly.
would suggest Bowen's, but
Great case.
unfortunately not. Okay, this one
Very educative.
This one appears to be difficult, but today we know it's a leg. It's a leg. Dermoscopy. Yeah, BCC. Dermoscopy suggests Bowen's, because you see dotted.
No, dermoscopy suggests lichen planus.
Oh, lichen planus also correct. Yeah. I was about to say that an alternative would be lichen planus, because the white lines are quite evident. But it could also be a BCC on the legs. On the legs, dotted vessels don't exclude BCC, and that was a BCC. All good. Okay. Next one. Clinically, what do you think it is?
Morphia.
Dermatofibrosarcoma protuberans.
Really?
Yeah, Morphia. This is a very specific location for a DFSP.
Bravo. Okay, good. That's good.
I thought morphia, to be honest.
Yeah.
Morphia.
We also thought morphia. We thought also sclerodermy from basal cell carcinoma.
Yeah.
Yeah.
Also possible.
Yeah, morphia. But as Jeppy said, that was a protuberance, and that's a variant. Although protuberance atrophic. Although protuberance in its name includes its tendency to become exophytic.
Protuberant.
Okay. However, there is this variant which is atrophic practically, and it mimics morphia. It mimics sclerodermy from BCC. And as JP said, the location is quite typical for protuberance. Very good. Okay, let me skip this. Let me show you this as the last one. Clinically, do you agree that this is Bowen's?
Bowen for sure.
Yes.
100%.
For sure.
Dermoscopically. Poroma.
Unbelievable. Look at it now again. Can you believe that this is a poroma? That's, by the way, that's an accidental diagnosis because that's so clear-cut Bowens that I don't remember why we decided to biopsy. I don't remember why.
Well, but don't you perform a biopsy as a rule in Bowens?
No, not
No.
always.
Not
Not
always?
always.
Not
Not
always?
always. Not
No.
always.
Okay.
No.
Amigos, I have a case of porocarcinoma mimicking Bowens disease. We can combine these two cases. Poroma, Bowens
But-
disease, porocarcinoma, Bowens
The
disease.
point is that this one does not only mimic Bowens disease. This is. I mean, look at it. Look
Yeah.
at it.
Yeah.
It's flat with scales on the top. Two lesions. Come on, you cannot believe anything else than Bowens and then Poroma. Okay,
Wonderful. Wonderful.
that's it
Wonderful.
from me, my friend.
Beautiful.
Fantastico.
Perfect. Beautiful cases.
Sebigno, go ahead. Go ahead. And then we continue with Costantino.
Did you see the bomb? We're gonna help you with our technology to find that ugly duckling every day in your practice.
I suppose they must have a director suggesting the story behind their videos. Unbelievable.
And also cinematographists.
Yeah.
No, but it's amazing what you can do with AI these days.
Yeah.
Incredible.
Va bene, Costantino, go ahead, go ahead.
I am going ahead. By the way, I love this episode with all these unexpected cases.
Yeah.
Okay, so unexpected results. Okay, patient 72 years old presents with this lesion in the leg. Patient reports that he has had there a lesion for 50 years. Okay?
See.
And he says that gradually it started changing and it created this appearance with this sort of pigmentation in the center, hyperkeratosis or pigmentation, hyperkeratosis.
Yeah, keratin.
Well,
And satellite lesions here.
Yeah.
You see it?
very, very, very suspicious for melanoma.
So my diagnosis was amelanotic melanoma.
Yeah.
possibly
Carcinoma.
in a congenital nevus.
So
Yeah.
this was exactly my diagnosis. A melanotic melanoma developing on a congenital nevus. So the diagnosis here was
VCC?
extramammary passage disease.
Wow.
So metastasis from adenocarcinoma of the rectum,
Yes.
colorectal,
Rectum.
that has attached to a former existing seborrheic keratosis here.
Oh my God.
Wow.
That
Oh
was
my
like
God.
the most impressive thing I've seen, to be honest.
Yeah.
Yeah, it's
Yeah.
really very interesting.
Yeah. Very
Yeah.
impressive, but it's reasonable to be impressive because a metastasis of
Yeah.
of an
Well,
adenocarcinoma.
yeah, and let's call it a metastasis, because if we call it extra mammary paget disease is a little bit confusing because
Metastasis.
Yeah,
You're right.
yeah.
You're right. But like it looks like a melanotic melanoma so much. So the pathologist, I have a very good pathologist and a good friend that I really trust. He took 1 month to give it back. He did 12 stains to get to the result. He just couldn't make sense of it. And we did the colonoscopy on Friday, and they found the carcinoma on the colon. This is not very surprising, but just a reminder to our audience. So this is a 38-year-old male. Sorry, wait. Give me just 1 second. Let me delete this. You saw that there was nothing on the free edge. So this is a 38-year-old male that presented with this lesion, sudden onset, recent onset, and this dermoscopy. I don't know what you would do. I performed short-term monitoring.
Yeah.
Mhm.
And this is the lesion 4 months after.
Oh.
Wow. How
Cool.
old?
38.
Uh-huh.
So
It's a
within
melanoma, clear-cut
Too
melanoma.
much even for melanoma, by the way.
yes, it was very impressive. Like within 4 months, this change, very impressive.
Yeah.
And the lesion was excised, and the diagnosis was this plastic nevus. Of course.
Okay, okay.
Come on.
Yeah.
It's not unacceptable
Uh,
diagnosis.
Yes.
But
No
you
way,
know,
no
I
way.
live for
No
the
way.
day that somebody will find and show a spitz nevus of the nail matrix growing like crazy in 3 months and then being a spitz.
Well, actually, do you think this could be a spitz? Well, in all cases, the thing is that just a reminder to everyone that the histopathologic criteria for lesions on the nail, especially early lesions, are very hard, and very commonly you will get this diagnosis. Biologically, of course, this is impossible. There's no nevus that grows like that.
Yeah, Costantino, but what was your management afterwards?
I excised the lesion completely.
But you
Yeah.
treated as a melanoma in situ, so removing entirely the nail plate, the nail matrix, and everything?
Treated just melanoma inside, of course,
Matrixectomy.
Okay.
of course. But this is just that you can get this result. Just don't believe it.
Yeah. Yeah.
Yeah. And this
And you can-
plastic nevus on the face also, it's not acceptable.
Yes, exactly. Another interesting case. This is a lesion on the leg of a 62-year-old female, been there for 2 years, and this is dermoscopy. You agree?
Poroma.
Why not?
Poroma.
Why not?
Of course. But the thing is that this patient excised the lesion outside our hospital and went to a non-expert pathologist. And she came back with a diagnosis of porocarcinoma.
Okay.
And when you get diagnoses that do not fit the concept, just ask for a consultation.
And
And of course, this was an eccrine poroma.
yeah.
But nonetheless, just keep this in mind. This one I'm showing because we had this discussion with Emilios the previous week, because he has never seen what are one of the pathways of melanoma development is on blue nevus, right?
Yeah.
So this is one. Because
Okay.
Emilia said
Okay.
she has never seen one.
Okay, this one I accept it because it is, I can see a blue nevus and I can see a melanoma developing just close to the blue nevus, just as a melanoma might develop close to a dermal nevus.
So, but yeah.
Yeah.
So, but the
Side by side,
pathologist,
not a collision.
so the pathologist interpreted the blue part as a blue nevus.
Yeah. It is
Right?
a blue
Okay.
nevus with a melanoma developing on top and destroying part of the blue nevus. The blue nevus was this part, and you can see remnants of the blue pigmentation here. So it's developing on top. And because Emilio said that he has never seen one, this is one.
Okay, good.
Yeah,
Emilio-
but no, I still I don't take it as one because I mean, you know what I said, and I said it many times, is that I cannot understand this pathway that they propose of a blue nevus transforming into a blue nevus melanocytoma and a blue nevus like melanoma. That's what I cannot understand. I can understand the coexistence rarely of a melanoma with blue nevus.
So I will never convince you.
Well, probably not.
I think like Emilios.
Maybe because I don't want to be convinced, you know.
Yeah.
Fair enough. Because we always treat blue nevi as nothing.
Yeah.
Okay, here on the chest of a 62-year-old male, has been there for 4 years. Clinically, what do you think?
BCC.
So
Extramammary pudgy disease.
this is the upper part of the lesion, and this is the lower part of the lesion.
Ah, squam
So,
cell, more on the side of squam cell.
so it's all a melanotic melanoma that has been treated for several years as seborrheic dermatitis, because it's exactly here
Yeah.
with steroids, and this was a 1.2 millimeter melanotic melanoma. I took the biopsy when I saw these vessels because they didn't fit with anything, and it was a melanocytic lesion. And actually, the melanoma extends from here to here and here and here and here up to here.
Yeah.
Yeah, that's a very strange one, but a great case.
I've shown this one before, but still, just to remember. So clinically, Jeppy, what do you think this is?
I remember this
Well,
case.
again, squamous cell versus EPD.
Yes. So this was a desmoplastic melanoma,
Ask
Ah.
him.
11.5 millimeter depth.
Yeah, I remember.
Yeah. It came as a big surprise. This one, this patient has the highest risk factor of them all, which is
Being a
risk
doctor.
factor.
she's a doctor, yes.
Ah, he's a doctor. Ah.
She's an orthopedic surgeon and came with this lesion. He's 56 years old.
Yeah,
It's melanoma.
yeah. It's
So-
schizoid thing.
It's melanoma.
So for some reason, in my mind, this was an atypical schizoid tumor,
Yeah.
and it came back as an atypical schizoid tumor. So I was pleasantly surprised. So this was pleasantly surprising.
Yeah, but
How old is the
it makes
patient?
sense.
65?
56.
56. So how did you manage the patient?
A wide excision.
Like melanoma?
No, wide local excision.
Mhm.
Yeah.
So
Baby.
this is a cultural observation. This is a migrant, and you can see the husband that also entered the examining room, whereas I always examine patients alone. But because of the cultural circumstances, I allowed the husband in. And this is a new lesion on the forearm, present there for 4 months. And this is dermoscopy. Patient
Very
is
young, very young or not?
32 years old, yeah.
It's yellow.
So what do you think?
You mean
very yellow.
xanthogranuloma like...
Antagranoma or
I
there are
excised this,
some vessels?
I excised this as JXJ, juvenile xanthogranuloma, and this was a tuberculoma,
Oh,
Okay,
solitary.
yeah.
okay.
It's
It
okay.
came- It came as a
The
surprise.
yellow
Yeah.
color maybe.
Still, I have to admit I was surprised.
Yeah.
This is a 36-year-old patient with this lesion, solitary. To be honest, not so impressive, but different than all the other lesions on the patient. So what would you do? I did a short-term monitoring, and this is follow-up. Change?
Short term?
Yes.
Yes, this is the short term.
But maybe the photograph is a little bit
progression.
different. Maybe there is more pressure in the
Yeah,
photograph.
but I mean there is an attenuation of this
Yeah, there is a
hyperpigmentation.
change.
Brown
There is a
structure is
change.
part.
There is a
Yeah.
change.
There's a pinch.
Yeah.
Subtle change, yeah.
So the impressive thing here for me is that my pathologist saw nothing but a very banal nevus, very banal.
Oh, okay.
But because we have this very good collaboration, in all other cases she wouldn't have done nothing. But she performed prime staining, and as you can see, there is prime lighting everywhere, literally everywhere.
Yeah.
So most likely this is the very early lesions that we managed to get right now due to dermoscopy. So the histopathology was insignificant, but the immunostaining was compatible with what we saw. I'm going to skip this, and I'm going to finish with a lesion that I always saw. I always saw because this has been so impressive and also traumatizing to me. 39-year-old patient with this fast-growing nodule on his scalp. I thought it was adnexal and sent it to the long list of excision. And this was a nodular yellow melanoma.
Yeah.
Mhm.
Ulcerated bleeding
Costa,
nodules.
can you show once again the blue nevus thing? Because when I saw it, immediately this brought in my mind something.
Here we go.
Okay, good, good.
Okay.
Okay.
Stop, sir.
Stop. Yeah. I will replace your share because I immediately came in my mind something that we saw recently, and what we saw recently was this, very recently, scalp.
Yes.
Yeah.
Mm-hmm.
And that's dermoscopy. I
Oh.
know that the focus, you don't see well.
Yeah, but it's
flat
very
part.
similar, pretty similar.
It's
Very
very
similar,
similar.
Rob.
Very similar.
So the
And-
flat part is looking like a blue nevus, definitely. It's out of focus here because the focus of the photograph is in the nodular part.
Melanoma arising on a cellular blue nevus.
Well, in my view, this is everything blue nevus.
Everything blue nevus.
Yeah.
Wow.
And you can imagine how analytically it was examined histopathologically. Yeah.
This is really very weird.
Really weird. Yeah.
This
Yeah.
one.
It's, you know what? It's something like, I mean,
Well, but because I mean, melanoma arising in a blue nevus is exceptional, like children melanoma. You know, it's like really an exceptional situation. Very good. Okay, we are running a little bit late, so I will share immediately my things. I will focus only on two scenarios. First scenario, let me, oops. Okay. Here we are. Just a moment. Okay.
I thought that I saw several questions before, but I see nothing here.
Yeah. But it's better to finish and then we keep
Okay.
we take some of the questions because we are quite late. Okay, let me show you this. This is let's say something like 45-year-old lady. We found on a regular screening this lesion here.
Mm-hmm.
This is dermoscopy.
BCC.
And this is a clear-cut
Microangular
BCC.
BCC?
Yeah, this is a clear-cut BCC, no question about it. But I took, I don't know, something like half an hour discussion with this lady to have this lesion removed because she was scared about the scar. And I mean, it was it was very complicated, you know. But finally, we were able to excise this lesion, and this was not a BCC.
Trichoblastoma. Trichoblastoma.
No, trichoepithelioma.
Same.
Yeah, same. Well, it's not actually the same because they are very similar histopathologically, but the trichoblastoma is not. It's the benign counterpart of BCC, while trichoepithelioma is just mimicking a BCC, and you know it's a completely benign stuff. So you could even leave it there. So.
Yeah.
I suppose the lady was a little bit disappointed, but just to remind you, the trichoepithelioma is mostly solitary, and there is a specific form of trichoepithelioma which is called desmoplastic trichoepithelioma, which is mimicking what?
Morphiaform BCC.
Morphiaform BCC.
Morphiaform BCC, exactly.
Oh, in this case, JP, we have to make it a couple with another case that I have. It's located in the same location and it's a morphiaform BCC.
Exactly. Yeah. So it's impossible. So trichoepithelioma is impossible to distinguish
Differentiate.
from BCC. No
BCC.
way. But there is a syndromic form of trichoepithelioma, which is
Bruch-Spiegler.
exactly. So you have this multiple skin-colored, shiny, small papules around the nose. Yeah, in some way also mimicking neurofibromatosis. Sorry, tuberosclerosis.
Adenomatosis.
Tuberosclerosis.
Tuberosclerosis.
Exactly.
Tuberosclerosis.
Tuberosclerosis. But when you see this, go first to check the scalp.
Yeah.
Because this syndrome
Syndrome.
is typified by
Syndrome.
multiple trichoepitheliomas on the face and multiple cylindromas on the
Syndrome
scalp.
on the
And this is
scalp.
what Nisa was saying, was mentioning Bruch-Spiegler syndrome. So this is a very rare disease, putting together these two adnexal tumors. Okay. And this was the first scenario. Second scenario. Now, I mean, come on, you make me passionate about this. Okay, so you have to distinguish these 15 cases very fast. Okay, very fast. Okay,
Seborrheic
go.
keratosis.
Seborrheic keratosis. Okay,
Keratosis.
okay, this one.
Melanoma.
Melanoma. Okay.
Yes.
Okay, melanoma. Third,
Melanoma.
melanoma. 4,
Sub-K.
Care.
Seb-K. 5,
BCC.
Eccrine poroma.
Dermatofibroma.
okay. 7,
Seborrheic keratosis.
seborrheic keratosis.
Seborrheic keratosis.
8,
Squamous cell.
squamous cell.
They're all
Squamous
eccrine
cell.
poromas.
Yeah, could be. Yeah.
9,
Eccrine
Poroma.
poroma.
10,
Poroma.
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 11.
Poroma. They're all eccrine
You
poromas.
understood the game. You understood the game. But look at this one.
Poroma.
Look at this one.
It's
Look at
horrible.
this one.
Poroma.
These were
Yeah, exactly.
all, these were all poromas. Ecrine
Great
poromas.
limiters.
Unbelievable. So we are able to distinguish ecrine poroma only when it's located on the sole and it's looking like this, with this kind of, let's say, come si chiama? Flowers?
Flower-like vessels, yes.
Yeah, flowers like
Pepe,
vessels.
I have dark skin counterpart of these poromas, all
Yeah.
pigmented and impossible to diagnose
Yeah,
in
impossible,
skin of color.
Yeah. Unbelievable. So poroma, as Emilia was always very nicely saying, is the great mimicker of everything.
Yeah, exactly.
So if
Great
syphilis,
cases, by the way.
if
All great
syphilis
cases.
is the great imitator of cutaneous disease of
Yeah.
reactions,
Yeah,
ecrine poroma is the great mimicker of tumors, by
Yeah.
all means.
yeah. Okay, good. Sebino, do you have anything for us before we proceed with Daria and Penelope?
This course is a great opportunity to learn a lot about dermoscopy.
And the professors have a really good reputation of being great educators and making it interesting.
The two professors combine deep expertise with humor, and that makes the course a little bit special.
They're fantastic. Their interaction is great and they are inspiring. I'm a plastic surgeon, so dermoscopy is a new skill that I've had to learn, and they make it look easier than it is.
Thank you. Thank you very much.
Do not change, stay the same.
Fantastico, fantastico, fantastico. Allora,
I love that they're all saying the two professors.
two
Just professors.
okay, can you see Daria?
Yes.
Can you
Yes.
see also firstly?
Yes.
Okay. Firstly, this is where Daria is located in
Yoshkarola.
Yoshkarola. Yeah.
Yoshkarola.
Yeah.
Nice.
Wonderful. So case number one, I mean, this episode, this presentation is fantastic. This lesion has been present for 15 years.
Poroma.
Now we know it, right? Now we exercised a little bit. This is this blossom flower or no?
Cherry blossom.
Cherry
Cherry
blossom.
blossom.
Cherry blossom. I mean, flowers like vessels. And this is, well, this is a UV dermoscopy, and this was ecrine poroma. Very good.
Uh-huh.
Case number 2, clinically, clear-cut BCC.
BCC.
Clearly.
Sub-K of very peculiar sub-K.
Okay, but in this particular case,
Melanoma?
polarized dermoscopy illuminated our diagnosis. Look at this. This is non-polarized
Melanoma.
dermoscopy. We have blue and we have black. There
So
is
it's
one possible
melanoma.
diagnosis.
Melanoma.
Melanoma, exactly. Blue and black.
Mhm.
Yeah. And this is a video of, I mean, you can see the single cells here, by the way.
Yeah.
Unbelievable. Melanoma 2.1. Impressive. This is a conventional, of course, it's not a lentigo malignant melanoma, it's a conventional melanoma on the face. And this is the most impressive case. This is a female, 36 years old. Lesion has been growing for 10 years. Oh, clear-cut PCC, right?
Not clear cut, but BCC.
Well,
Mhm.
on the face.
Yeah.
But we have a follow-up after 2 years. Probably the patient didn't want to remove the lesion.
Uh-huh.
Oh my God.
Melanoma.
And look at the, yeah, there is a little bit of polypoid the structure. Look at the
Wow.
horrible.
Wow.
Horrible. Especially the polarized dermoscopy is horrible.
What's
But if
the
you look at
difference?
this image, you can recall the image of my lesion located on the finger on the toe.
Yes.
On the toe.
Yeah.
Because
So
this
It's
is
ecrine
Is this a
poroma.
full
The poroma.
Really?
only a poroma.
Wow.
Okay.
That's amazing.
Unbelievable.
I can imagine the
Well, I think
feeling.
this should be
feeling-
porocarcinoma, not poroma.
Yeah.
I can imagine the feeling in the days waiting for the pathologic report.
Yeah.
And the relief of the patient, 36-year-old. Come on, this would be a polypoid melanoma. Super
Polypoid.
bad.
Super aggressive. Look how, by the way, in sub UV, how beautiful are these vessels. Unbelievable. Wonderful. Thank you, Daria.
Thank you, Daria. Amazing
Thank
cases.
you.
Amazing cases.
Bravo.
Bravo.
Oh, as always.
Perfetto. Emilio.
So
show
today
us
is
what-
Poroma Day.
Poroma Day, of
Poroma
course.
Day,
The
yeah.
unexpected, the king of the unexpected
king of the unexpected,
results.
yeah. Okay, 79-year-old. Onychodystrophy for 3 years. Stable. That's what you see with dermoscopy. That's what you see
SCC.
on the free edge.
Squamous
Diagnosis.
cell carcinoma.
Most reasonable diagnosis should be squamous cell, subungual hyperkeratosis, onycholysis. Okay, that's
okay.
not surprising. Yeah, that's reasonable. Okay, good.
Yeah.
Originated from bowenoid keratosis. Okay, good.
Yes,
Very good.
we have to remember, this is a good case to remember that the mostly squamous cell carcinoma originate from the nail bed or the periungual skin. Okay, so it's important to remember.
Yeah. And when this is the case, then you don't see a leukonychic. You don't see a band. Yeah.
You don't see the band. Yeah.
Okay, Still nail, 39. Come on, this looks so much like
Onychomatricoma. It should be.
Onychopapilloma.
papilloma. I would say.
Papilloma.
Papilloma.
I would say
Papilloma.
papilloma. Yeah.
Okay.
Go for dermoscopy.
Dermoscopy.
And this
Yeah.
is of
Papilloma.
course this is blood. This is blood.
Blood.
Yeah,
Yeah. Of course.
Onychopapilloma.
Onychopapilloma.
Onychopapilloma. Onychopapilloma. Multiple filiform hemorrhages. Typical the subungual hyperkeratotic growth. Yeah, it should be onychopapilloma. Thinning of the nail plate also. Clear cut onychopapilloma. Very good.
Beautiful.
Number 3, Bowens.
Okay.
Rounded lesion on the instep. Yeah, could be also eczema, of course. Bowens, come on.
Yeah.
Nose.
Yeah.
UV. What do you see in the UV?
Yeah.
I don't know.
Nose.
Vessels. Oh, yeah.
Okay.
Yeah,
WA.
the vessel. Oh, sorry. Diagnosis. We still remain with Bowens, no?
Yes,
We still remain with Bowens.
Okay. Monomorphous glomerular vascular pattern plus thick white scales. Typical Bowens.
Grazie, Penelope.
What
This is
else, Penelope,
great.
today?
This is great for this episode because we were
Yes, we saw all the impossible.
To balance
We
a
are
little
very
bit.
happy with the diagnosis. Thank you, Pascal.
Okay, leg 79. Brown
Melanoma.
Yeah, melanoma
or pigmented Bowens.
Or pigmented Bowens or subcare. Yeah, let's see.
Pigmented Bowens.
Pigmented Bowens could be.
Bowens.
Could be.
Yeah. Okay, so we biopsy this one, no?
Yeah.
Biopsy for sure.
Definitely.
This one we biopsy.
To rule out melanoma, but it will be both.
It will be Bowens.
Yeah. There are these linear dots.
Well, and I mean here the main differential diagnosis is between Bowen and SEPK, by the way.
Keratosis. Okay, also lentiginous melanoma. It's not.
Well,
lentiginous
I would
melanoma.
say less probable.
Less probable, yeah, but good.
Yeah.
UV diagnosis.
And
Okay, we remain with Bowens as the first.
Yeah.
Yes.
second, melanoma.
Patches of brown to gray dots in a linear arrangement. Brown gray structureless areas.
Bowens is coming.
Prominent skin markings. Pigmented Bowens. Wow, nice. And the last one. Can you imagine the one for Sebi will be the crazy one?
Of course.
Numerous non-melanoma skin cancers, spiral sedation, numerous actinic keratosis, photo damaged scalp, of course.
Poorly differentiated.
Okay.
Poorly
SCC.
differentiated.
Very yellow. Very yellow.
Yeah, poorly
Very
differentiated.
yellow.
SCC.
Very yellow.
Yeah, but
of course,
what else?
and of course,
What else?
coming from this episode, I would
Poroma.
not exclude Poroma. Exactly.
No, Merkel cell.
Now,
Poorly differentiated SCCI.
yeah, squamous. It should be
Squamous
squamous.
cell. Squamous cell.
Diffuse distribution of numerous, mainly coiled with hemorrhages. Yeah, orange background.
Okay.
Fair enough.
Inside to squamous cell. Very good.
Very good.
We are so
Excellent.
happy. We are so
Wonderful.
happy. Great.
I forgot that we have to do the Kahoot also, guys. Say something.
Would you like to listen the entire concert we did yesterday?
Yes.
Say something.
Okay, so we'll ask the audience, which was the most impressive case that you saw?
But do we have some questions to reply?
But where are they? You said before there are
I
questions.
saw some questions, but they disappeared. So Doriana Massimino asks if Poroma changes over time.
Yes, it does change.
Obviously.
Yeah. It does
As
change.
Daria showed.
Yeah, it does change.
And I have a question from last episode. What was the diagnosis of the large brown and desquamative frontal lesion? Oh, here.
Oh,
The actinic keratosis and squamous cell carcinoma in situ. You remember the patient that I applied imiquimod on, and he also had the BC?
No.
No. Yeah.
My
No.
short-term memory is completely fake.
Let me see if I have it somewhere here. Talks and conferences, the HH.
Should I go or wait for you?
Go.
Give me just 1 second. One
Yeah.
second.
Okay.
No, not here. Well, go. I like an elderly gentleman with a lot of lesions on the scalp. Whatever. Done. Go.
Okay. Perfetto, perfetto. Ragazzi, we are almost there. 3 episodes.
Yes.
And next week we have an episode, but then we have to make a 1 week stop. Why?
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 Yeah, why? Of course, why?
Why, Zepi?
Of course, why? Yes,
Because all of you, all 10,000 people that are that are watching the happy hour in Zoom and YouTube are invited to celebrate together with us Jeppy's 30th birthday.
30. Yes, we do a nice party all together. So on Sunday, May 10th. So we will
in Napoli Football Stadium, we celebrate Jeppy's birthday with all the people that love you around the world. So if all the people that love you around the world come together, the Napoli Stadium would be enough or not?
No.
Okay, how many we have? 162.
162. In my view, we can go.
Yeah. Let's go.
Wait.
Okay, I think that I have a very easy Kahoot, but okay.
Let's see.
Easy.
I think so.
Okay.
Case number 1, ear, ulcerated lesion, as you can see, very ulcerated. That's dermoscopy.
Very ugly.
The question is, what do you think it is? Do you think that it's
benign,
PCC and SCC, melanoma, or Merkel?
Well, I think there are 2 diagnoses here.
Yeah.
Yes, but the correct is only 1.
Oh, but I missed the clinical. From here, I would say
very
no way
ulcerated
to say.
lesion.
No way to say. Probably there are 2. Yeah.
Very easy, Kahoot, 29.
Come on, what do you mean?
No, okay, it was not easy. Yeah, finally.
Like my differential was Merkel first and squamous cell carcinoma below.
Yeah,
but
I
it's
thought
because
fully differentiates the SCC for me.
it was very much ulcerated. So when it's very much ulcerated, but look at it, there are some big vessels in the center.
But for sure, Emilius, it's clear
fully
cut.
differentiated. Yeah.
Oh my God, disaster. Disaster. Only the navigator loves me. The navigator and piano. Case number 2, clinical, dermoscopy.
Okay.
Again, ulcerated lesion.
Yes.
What do you think it is? Same options.
Let's hope.
I don't hope to anything anymore. I don't say nothing.
So, guys in the audience, remember the Kahoot that I prepared last week? Think how better I am. I'm a better person. Okay.
Okay.
Grande.
Okay. Squemusel, very good. Now, Seboquero, followed by Dermblasen Poroma 8, which brings us to case number 3. That's the clinical, that's
Okay.
dermoscopy.
Okay. Be nice. Be
And
kind.
the question is, what do you think it is? Options are BCC, SCC, melanoma, other.
If it's
Other
not,
is a very dangerous
When you
choice.
have other, you always have to vote for other.
if it's not
Yeah.
other, I will jump from the balcony, and I'm on the 4th floor.
Can't or
Come on.
What kind of other? I don't tell you.
Sepcare.
Sepke.
Okay, good. Good. What happened here is that Seboquero,
Seboquero, of course.
Of course.
Of course.
Dr. Sealer, I know this name. Trium Poroma is
Nice.
and Poroma 8.
Poroma 8.
Okay, a challenging case. Woman, 54 years old. That's leg, as you can see.
Very solitary.
Very solitary. Very solitary. Small. Very
Okay.
solitary. Dermoscopy is this.
Yes.
Okay.
We excised it.
Mm-hmm.
And now, try to guess what result did we get from the pathologist.
Write 3 options.
No.
What?
No, Emilio.
No. It's reasonable.
Okay.
I think. Okay, Nivus.
Okay. Fair enough.
Okay.
Very good.
But you understand the challenge of the context. I mean, you have a very solitary lesion on the leg of a woman in 54, but it's okay. It's not so ugly. You get the result, nevus with slight atypia. You're not convinced if it is in fact a nevus or if it's a very early melanoma that is still, but it's okay. It's excised, done.
So a lesion that must be excised.
Yeah.
Or you can also do a short-term follow-up.
Yeah, but why? It's so small, so very good.
Lonely duckling.
Very good. Poroma 8 now is on the lead, piano and Nivus.
I think Seboquero vote for
Last
Sepke.
case. Last case. Scalp. Dermoscopy.
Oh, che bello.
And the question is, type the answer. Can you give a name?
Wait.
Yes.
How do I do it? And it does like this? Wait.
Can you give a name? Give a name.
What does Zoom do when I do this? It pops something?
Yeah, but now I didn't.
Not now. Look at me.
Bum.
Boom. Okay. Balloon. Only 3.
Only 3. Mamma mia.
Come on. Wow.
So we have just 3 answers.
Well, so the podium must be of people who are incredibly
Dolce Vita. And the winner for the day is Poroma 8. Fair.
8.
It's fair enough because I mean today it was the Poroma day, so we should.
Yeah, exactly.
Yeah, we should finish with this.
Wonderful. Well, no, but it was a nice scout. Don't be disappointed.
No, it was nice.
Yeah.
I mean, okay.
Nice cases.
Yeah.
Next time I'm gonna show you, leaf-like areas and say, what is this? BCC. Yeah. Lacunas, what is this? Angioma. Wow.
No, perfetto.
Are you making fun of me?
Perfetto. But who is Poroma 8, by the way?
Poroma 8.
So who is Poroma 8?
Poroma 8.
Poroma 8.
Of course, Taha is saying that she was misspelling.
Misspelled.
Yeah.
Yes.
Who? What?
Taha said that they misspelled.
Ah, they misspelled.
Yeah, this
Balloon,
is the problem.
balloon.
Yeah.
Perfetto, perfetto, perfetto.
But we didn't see who is Poroma 8, eh?
No, they didn't
No.
reply.
No.
Poroma 8.
And balloniform. Yeah.
Poroma 8, we don't know who you are, but we love you anyway.
We love you so much.
Yeah.
Okay, so next episode May May the 2nd.
Third.
No, maybe the 3rd.
May the 3rd.
Then a break, and then we go on May 17th. Okay, wonderful. Va
Absolutely.
bene, ragazzi.
Wonderful.
Where's Sebi?
Where is Sebi? Sebino.
Pinho.
But Sabino changed also. He does not wear anymore the.
Well, it's
fancy
cold.
shoes.
It's becoming cold.
Yeah.
Yeah. Va bene, ragazzi. Have a great evening. Have a great morning. Have a great day.
By the way, let's just say that the winner was Ivan Ramos, but cannot connect the camera. So Ivan,
Congratulations.
Bravo.
Bravo,
Ivan.
Poroma 8, Ivan.
Va bene.
bye guys.
Bye.
Love you guys. Bye bye.
Take care.